everyone. Welcome to the second webinar of our Delivery Systems for Scale webinar series. This one is focused on where exceptional circumstances are not so exceptional. And we're going to be talking about a strategic approach to adapting the management of child wasting in emergency-prone contexts, including through the use of simplified approaches. I do want to mention that this webinar is being offered in 4 different languages. If you look down at the bottom of your screen, you'll see a little globe that has interpretation. We are offering interpretation in French, Spanish, and Arabic, and I'd like to thank our translators, Claudia, Carmelo, and Rashid, for being with us today. As I mentioned, the Delivery Systems for Scale project, it is a project implemented in partnership between UNICEF, the International Rescue Committee, Action Against Hunger, and Save the Children. And for this webinar, we are hosted through the Global Nutrition Cluster's Technical Alliance with support from the following donors: USAID, Irish Aid, UNICEF, and the Canadian government. So what is the Delivery Systems for Scale project, you might ask? It is a project that has been implemented from 2022 to 2023, and we provide both technical and coordination support to scale wasting treatment within a variety of high priority focus countries that were related to the USAID's Bureau of Humanitarian Assistance supplemental funding that was allocated to accelerate bringing wasting treatment to scale back in 2022. This is the culmination of our project, and we're talking about some of the main themes that came up in our engagement with countries over the course of this project. And today, this webinar will focus specifically on highlighting the work of a couple countries who have established that more strategic approach to adapt the management of child wasting in exceptional circumstances specifically. So we hope to better understand, support, and learn from their experience today. We'll go through brief introductions, and then I'll hand it over for some opening remarks to UNICEF, and then we'll dive into the country experiences from both Somalia and Nigeria, looping back to have a good amount of time for questions and answers from the audience before a brief closing. So as you hear from the countries today, please do save those questions and make sure that you're sharing them with us so that we can come back to them in the discussion section. I am happy to say we have a very great panel today. You have myself, my name is Ellen Yakowenko. I'm the Project Director for Scaling Nutrition based at IRC. We will have opening remarks from Grace Fennell, who's a nutrition specialist in child wasting based in UNICEF. Then we have Martha Nakakande, who's the CMAM and IYCFE tech advisor on the technical support team of the GNC Technical Alliance, and she is based at the International Medical Corps. She'll be leading the facilitation of our discussion section and also helping us to prioritize the questions as they're coming in from you all. And then the real meat of our discussion today is going to be based around the country experiences of both Somalia and Nigeria. So from Somalia, I'm happy to report we have Simon Karanja, who's the Nutrition Cluster Coordinator based in UNICEF, and Gabriel Okram, who's the Emergency Nutrition Specialist, also based within UNICEF Somalia. And then from Nigeria, we have Solomon Atuman, who's the nutrition coordinator based in FHI 360 in Nigeria. So we have a great panel here. And with that, I hand it over to you, Grace, for opening remarks from UNICEF's side.
Thank you, Ellen, and good afternoon, good morning, everyone. Very happy to be here with you all and to discuss our exciting topic for today. My name is Grace Fennell, as Ellen has already introduced me. Next slide, please, Ellen. Thanks. So today we're here to talk about exceptional circumstances. We know that in countries where we're all working, we're seeing more and more emergencies, more protracted emergencies, and we want to learn today, as Ellen mentioned, from countries that have looked at some adaptations to the standard protocol. So just setting the stage, according to the 2022 Global Report on Food Crisis, a total of 42 countries experience high levels of food and nutrition insecurity. 8 million children with severe wasting and 27 million children are living in severe food insecurity in 15 countries alone. We know not only are these emergencies happening more often, they're more protracted, they're more intense, and they're happening at bigger scales than we've seen in the past. In these contexts, we know that we need to continue efforts to ensure children are detected and treated for wasting, and that this management of wasting is critical to ensure that these children survive. Exceptional circumstances, there is no clear-cut definition, but it typically refers to a complex or challenging context resulting in negative effects on treatment services or on the target population. While there's no set criteria to determine an exceptional circumstances, there are a number of contextual questions to consider when looking at your context. A number of questions such as accessibility of health services, deterioration of the nutrition situation, resulting in increased rates of child wasting, pipeline breaks, etc. So today we will cover what some of these countries encountered as they were looking at adaptations to their national protocols. Next slide, please. As you all are aware, the new WHO guidelines on prevention and management of child wasting were recently released, and they really provide the gold standard for programming. As is noted in the briefs that are accompany these guidelines, in exceptional circumstances and as a response to a time-bound acute emergency, some adaptations to standard protocols may be required, and these should remain for emergency-only programming and services. I say this because while the new guidelines don't explicitly lay out when an emergency is defined, we do know that they do acknowledge that emergencies happen and adaptations are needed. However, the simplified approaches are not part of the new WHO guidelines. They have existed in the past and were defined as a package of interventions to increase coverage, to ensure continuity of services during emergencies, etc. But the new WHO guidelines do not promote the use of simplified approaches. As we know, some of them were included in the new recommendations, such as delivery by CHW treatment. I'm noting this because sometimes there has been confusion around this, and I would suggest for those of you who haven't to please review the GNC presentation that was given by WHO and UNICEF, in which the new guidelines were presented, and I'll be copying the link to that webinar in the chat. Next slide, please. As mentioned, the simplified approaches have been instrumental in testing new ways of delivering services to children and their families in a variety of contexts, including emergencies. The simplified approaches are a package of interventions. There are 7 unique interventions. Sometimes they're implemented as a bundle, 2 or 3 of the adaptations. Sometimes it's just 1, sometimes it's all of them, but they are indeed 7 separate interventions. And when speaking about the simplified approaches, it's important that we're clear about which specific simplifications are being referred to. As mentioned, we know many countries adapted some of these modifications during COVID, and we saw an increase in the number of countries that were looking at these adaptations during COVID. And some countries have gone a step further and have defined certain adaptations to be adopted during emergencies and their national protocols under emergency SOPs. These efforts require very close coordination with the MOH and key stakeholders at the country level to define when and where to activate some of these adaptations to ensure services, and discussions on when we can revert back to regular programming. So today we're here to learn more about these experiences in 2 countries. And so I'd turn it over to our colleagues from Somalia. Thank you.
Good afternoon, good morning, good evening, everyone. My name is Simon Karanja. the Nutrition Cluster Coordinator based in Mogadishu. I'm together here with my colleague Gabriel Ochong, who is a nutrition specialist, also based in Mogadishu. So I'll give the presentation based on our experience here in Somalia. Next slide. In Somalia, for this particular presentation, it's based on the development of what we call SOP for activation of simplified approaches, and also for our experience in terms of developing guidelines for family work scale-up. During last year drought in Somalia, we encountered quite a number of challenges, and that is some of the challenges that necessitated us to develop these strategies in order to be able to institutionalize or strategically implement these approaches. One of the main challenges was that there was gaps in terms of the mom treatment due to pipeline issues. There were frequent stockout. There was also very poor coverage in the rural areas and how to reach areas. Somalia infrastructure is quite poor, so accessibility is very limited outside the major towns, while the majority of the population are still in the rural areas. And due to insecurity, we still have a lot of areas that are, severe constraints in terms of access. Of course, another issue that necessitated the development of this strategy is to ensure that the continuum of care. In Somalia, the services for both treatment of SAM and MAM were in different co-locations. So the proportions of where we had co-locations for the treatment of MAM and SAM was quite low. And therefore, the continuum of care, the referrals was not easy. And because of this is another reason. And lastly, due to the very weak public health system, including community health workers, we had issues with early detections. And therefore, we thought that scaling up these approaches would strengthen the early detections and referrals. Next slide. The purpose of these strategies was to ensure that there is a clarity. Somalia is quite vast and quite diverse. The needs are very high, while the resources are quite limited. Was to offer a clear guidelines on when, where, and what approaches to be activated in different locations. We have very diverse in terms of geography, in terms of the nutrition status, in terms of ethnic and population profile, IDPs, rural areas. And therefore, we required a strategy on how and when, in a very transparent manner, on how these activations could be a guidance to these activations. And of course, being a country with very high caseload of acute malnutrition, the issues of supplies management comes in, and therefore there was a need to have a systematic framework to ensure that supplies issues are sorted out. With the issues of interventions of exceptional simplified protocols, they have been tried before in Somalia, but documenting such initiative was very difficult because there were no tools or even reporting channels to gather and collect data from these approaches. And also, at the end of the day, it is important to document lessons learned and to generate evidence if these approaches are making an impact in Somalia. So the strategies, both the SOP, the Standard Operating Protocol, and the family more guidelines were designed in order to address all these issues. In both the SOP and the family more guidance, there was a very lengthy and consultative process on how the strategy was developed. Initially, for both documents, I, as the nutrition cluster, developed the zero draft based on the global tools. The zero draft, again, was shared with the key nutrition partners, UNICEF, WFP, for their input, as these are the two UN agencies that largely support the implementation of IMAM scale-up. We know UNICEF supports the treatment of some, and WFP the treatment of moderate acute malnutrition. Once WFP and UNICEF made their input to the draft, this draft was presented to the IMAM Technical Working Group, and there was a series of meetings, consultative meetings, discussions to refine the document much further to ensure that it addresses the context of Somalia. It is all about contextualizing and making the guidelines as practical as possible. During the same process, we also requested the assistance from the UNICEF Regional Office and also from the Global Nutrition Cluster Technical Alliance to support in drafting the two documents, and especially the SOP for the activation of the approaches. And we got excellent support from UNICEF Regional Office and the GNCTA. Once we felt that the document now it's in terms of presentation, how practical it is. This was presented to the all cluster partners. There was several sessions to ensure that all clusters understand what is the objective, the purpose of the document. We got a lot of input, and once all these were presented, also when we talk of the cluster-wide presentation, this includes the government Ministry of Health, both at the national level and the state level and the regional level. And thereafter, this was again presented to the nutrition cluster SAG for endorsement. And finally, after the endorsement from the nutrition cluster, it was presented to the Federal Ministry of Health for endorsement. And the Federal Ministry of Health has so far done what we call a provisional endorsement. And this is the draft we are using for the implementation. So just to say, it was a very long process to refine the document. Here I will address mostly what the strategy in terms of SOP for activation. The bulk of it, it's simply that it describes the scenario for activation, have several scenarios. And these scenarios it's where a lot of the discussions back and forth were in terms of which are the key scenarios, which are the practical scenarios, which are the measurable scenarios and able to verify. And then guidance on the approaches to be adopted, whether it's expanded admission criteria, whether it's a single product or family work. And in addition to that, there's also a deactivation scenario criteria. At what point should we go back to normal programming? Again, this is an area there was a lot of discussion. As you can see, one of the key scenarios is the issue of pipeline, the pipeline status, and also deactivation is when, for example, the pipeline situation is back to normal, as you can see. Next slide. This is also another set of scenarios that is based on the accessibility, whether it's hard to reach, and again, the approaches to be adopted, and also the main deactivation criteria. As I mentioned earlier, the issue of access in Somalia is critical, and that's why it's one of the key scenarios that was included in the SOP. Next slide. As mentioned, this was a very lengthy and a long process in terms of developing the guidelines. Here I will present some of the challenges that we came across. One of the issues in Somalia is lack of nutritional data, timely and comprehensive. As you can see, one of the key scenarios is the GAM rates and also the supply stock status. Unfortunately, in Somalia, there is one or two assessments. There are actually two assessments, large-scale assessments done by the Food Security and Nutrition Analysis Unit. So we don't have that real-time data to be able to use it to develop a more precise guideline. We also lack a comprehensive surveillance system. And as you can see, one of the recommendations is to invest in a surveillance system, in a continuous surveillance system to be able to track especially the nutrition situation at a much lower level sub-district. This is also the same linked to, as I mentioned, FSNU conducts their studies based on livelihoods, while the planning in Somalia is based on the administrative, and therefore the data is deemed not to be very accurate because it's an estimate based from the livelihood level, and also because it misses out on the pockets of high malnutrition or low malnutrition. A district can have both very high levels of malnutrition and very low levels of malnutrition. And we are advocating for partners to conduct more surveys to complement what FSNU is doing. Of course, again, it's related to data is the issue of tracking the supplies, especially at the lower levels, because as you have seen, one of the criteria is if the area, if it's in terms of stock status. Again, this is a work in progress in terms if the process of activation would be effective, then we really require site level monitoring of supplies. One of the other challenge was the delay in terms of formal approval from FOMH. And basically this is could be contributed because it's a new approach. It's a new approach. Somali had just done completed its IMAM guidelines, and then we bring in another additional guidelines on top of that. It proved a challenge, but as I said, we got the provisional approval. But this will require a lot of capacity building within the Ministry of Health to understand the relationship between all the guidelines, all address the same problems. And we're currently doing very high level advocacy to fast track formal endorsements. As I said, one of the other challenges and that required a lot of discussion was this fear that the simplified approach, and especially the use of single product, will fall on UNICEF. There was a perception that partners prefer the use of RTF because of historical reasons, how WFP and their logistics areas, and therefore the MAM caseload is nearly 3 times that of SAM. And with that, it required a very, the activation to be done in such a way that it will not become burden upon UNICEF, because the projection was that in most of the cases, the burden will fall on UNICEF because there's more pipeline break within the MAM supplies. And that had to be addressed, and especially the concerns from UNICEF that it will bear the burden and also have the burden to fundraise. Of course, this issue is very valid, and that's why it requires in the activation process to have very, very precise data, so that only the areas that are highly need are identified and activated, critical areas. But at the moment also, UNICEF WFP commitment to support the approach, which currently is in place. As I said, the challenge again was WFP is targeting 100% of the MAM, and one of the main reasons for activating the simplified techniques that partners agencies were requesting is because WFP does not provide enough supplies to reach all cases. And enough for it was to bring is if WFP is targeting 100% and they have resources for 100% of the MAM cases, there should be no need to activate simplified approaches, especially, for example, expanded criteria or simplified approach. And we are working on this to see the projection versus the actual program admission, to see where we are missing out. Are we underestimating the MAM caseload? Or what is the issue? So this is something that also the IPC GSU is supporting to see where the difference is coming. One of the challenges also is the issue of the fear for aid diversion because of lack of a very strong supplies monitoring. and therefore need to invest in real-time monitoring of supplies. Next. And again, as I said, the issue of the use of the single product ready-to-use therapeutic food and RUSF. One of the recommendation, and also we are working on, is to ensure that there is a co-location for OTP and TSFP to ensure that if there's any activation in a particular area, it will be easier to coordinate and cheaper. The one agencies could be funded by both organizations could be cheaper. The other general challenge is lack of technical capacity. Most of these are new approaches, and especially from the frontline health workers. There's a lot of confusion between what is single product use, what is expanded admission criteria, family work. All this is still very much new in terms, especially at the subnational level. Currently, we have there was also a lot of debate because when we talk of in most cases, use of RUTF to treat mom and vulnerable mom, the question here, a lot of the discussion, what does vulnerable mom means in real terms? And this is, if we're able to answer this question, then it will be possible to do targeting at the individual level, while currently we are looking at a very wide district level targeting, for example, vulnerable mom. Next slide. Again, in Somalia, this is issue of very low field monitoring, and this is very related to access. And it's fear that, for example, approaches like community-led treatment might lead to aid diversion because there's no way to monitor them or going out there. Where will they store the supplies? And what the recommendation is here is to develop very robust monitoring strategies. But in some cases, we have no choice but to do no regrets approach, especially in areas that have very high access constraints. And of course, generally in terms of information management, the current reporting system cannot capture data from, as I mentioned earlier, data from these approaches. The system has been in place for a very, very, very long time. And therefore they require the current system to redefine the indicators, to develop reporting tools and disseminate all this to the health facility level. And one of the questions is that if mom treatment is done at the OTP, who should report it? How is it reported? And those some of the issues that we were struggling with in terms of to ensure that how do we capture data, especially for example in expanded in the area that are using single product. How do was this work, reported? Next slide. As I mentioned earlier, both the family work guidelines and SOP after provisional approval. And using the SOP, we're able to activate expanded admission criteria in 3 districts, which is cluster endorsed and UNICEF supported. The family work rollout is still not in scale, but it also depends on the available resources. Looking forward, we have quite a number of opportunities on further strengthening these approaches. The first one, we are planning to do an IMAM scale-up framework development, what I call nutrition cluster strategies and response plan. And one of the plan is to embed and strengthen the use of these approaches in exceptional circumstances. There's also a plan to revise the IMAM guideline, and also the plan to during the revision is to include a chapter on exceptional circumstances. There's also a very clear commitment from the country, UNICEF and WFP to support these approaches. We have significantly improved the subnational coordination at the district level, so we will be able to verify data, information, and the context. One of the areas that we're also planning to do is rationalize sites. There's a lot of fragmentation in Somalia that will make it easier to coordinate and also to roll out some of these approaches. There's also a plan to migrate to DHIS2. DHIS2 will also, this process, give us the opportunity to look at the reporting tools, embed reporting of simplified approaches in the tools, and also because the DHIS2 require training of all health workers, is an excellent opportunity also to train, to create awareness of the simplified approach across the frontline workers. And of course, there's a global action plan, which has early detection and use of simplified approaches as one of the priorities. And again, part of the commitment from UNICEF and WFP and other UN agencies to support the process. One of the areas that need additional support is advocacy workshops targeting very high level government officials for endorsement and buying. As I mentioned, there's a lot of confusion. What is the role of the IMAM guidelines? And then we have these layers of additional guidelines. So there's a required to have extremely high buy-in in government. The current Ministry of Health are very supportive, but also they would like to see a very clear understanding and clear, of what are the purposes of all these different guidelines, and probably be able to bring them into one document. And of course, continuous capacity building, benchmarking to see in similar context that has, successfully implemented these approaches in scale and learn from them. Critical issues is to try and define this, what is, vulnerable MAM, GAM, who are these, exactly what that means. And of course, we require support to embed this exceptional approach, these approaches in MM guidelines, across all areas. And of course, development of tools to capture these approaches is very critical. Thank you.
Yeah, good afternoon, good morning, everybody. My name is Solomon Atuman from FHI 360 Nigeria. So I will be taking the Nigeria experience. Next slide, please. Yeah, so in 2022, last year, when we did a trend analysis of the admission for severe wasting and moderate wasting across our implementing facilities, we found out that there was a very high rate of admission last year, precisely about 52% for severe wasting, and about twofold more moderate wasting compared to the same period in 2021. And this was caused by, this was majorly more severe in Borno State, out of the Bay State, and we found out that this several drivers were involved in this spike in admission, including but not limited to disruption of humanitarian assistance due to the protracted conflicts. We have delayed funding or funding cuts across partners. There were outbreaks of communicable diseases around the Bay States. We had food shortages and spikes in food prices. We have relocation of IDPs around town. Of course, there's the issue of inaccessibility to several local government areas, and low coverage of preventive services. So generally, the strategy was developed to address the difficulty in the delivery of life-saving treatments in hard-to-reach areas. Also to mitigate against the effect of the delayed scale-up of services. Of course, not limited to the low coverage of nutrition services in these hard-to-reach areas as well, and areas where because due to lack of funding and other constrained activities cannot be taken to that area. This strategy was also developed partly to curtail some of the implementation challenges faced, such as pipeline breaks, challenges with supervision, and limited or unavailability of health personnel and their capacity in the hard-to-reach areas as well. Limited accessibility to existing health facilities was another reason why the strategy was developed. And the sector felt that any other exceptional circumstances that will be agreed upon can go in line with this strategy. Next slide, please. So the purpose for development of this strategy is basically three. The simplified approach was developed to improve coverage and access to life-saving treatment services for uncomplicated wasting, to also provide a continuum of care for children 6 to 59 months with wasting in hard-to-reach areas. Generally, what we found was because the OTP services for severe wasting, uncomplicated severe wasting, was generally much more than the coverage for the moderate wasting. This was part of the purpose was to be able to match this to ensure that the continuum of care is at least at 50% each of the service distribution. And then it's generally to contribute to the generation of evidence on simplified approaches and sharing of lessons learned in Nigeria for the simplified approach. Next slide, please. So how was the strategy developed? This was a very lengthy and complex process. I'll try to just bring it out as streamlined as possible. So it was an activity that was assigned to the IMAM Technical Working Group, who developed the Draft Zero and built scenarios and defined scenarios, as we will see in the presentation going forward. So several scenarios were brought up, and definitions and criteria were used to define this. After that was done, it was now presented generally to the nutrition sector for the Northeast Nigeria, where a lot of deliberations happened, and then we had to go back to the IMAM Technical Working Group to fine-tune some of those suggestions and deliberation that happened at the cluster level. After that was done, it was a presentation to the State Primary Healthcare Development Agency, of course, with the State Ministry of Health in the Bay States as custodian of this approaches. Of course, we also received inputs from them, and while this was happening, also we had inputs from the UN agency, specifically talking about WFP and UNICEF, who are pipeline managers for the commodities used for treatment of wasting in this part of the country. WFP is saddled with the responsibility of treatment of moderate wasting, while UNICEF for that of severe wasting. We received several inputs from them, and it was incorporated into the draft. And also, we also had support from the Global Nutrition Cluster, technical support team, and Martha was very, very generous to provide her technical support to us during this process. We had several scenarios which were not clearly defined, streamlined to be able to reduce ambiguity and provide clear guidance for whoever will be using the simplified approaches. After that was done, we were able to get audience with the Federal Ministry of Health, who reviewed, and also a presentation was done with the Federal Ministry of Health and the National Primary Healthcare Development Agency, where after this presentation, we had inputs and incorporated, and it was finally validated by the Federal Ministry of Health as the final draft of the Northeast Nigeria SOP for simplified approaches. Next slide, please. So what does the strategy contain? Basically for Nigeria, we had 6 sets of adaptations incorporated in the SOP for the simplified approaches. The first one was expanded MWAC admission criteria to include children who are at borderline of wasting, talking about children with MWAC 12.5 centimeter. The next is the use of single treatment product, talking about using of RETF for the treatment of both severe and moderate wasting. However, in this, we also agreed that RETF can be used for the treatment of moderate wasting, but RESF cannot be used for the treatment of severe wasting. And the third one is community health worker-led treatment of wasting in the management of wasting by especially with in district and local government where there is limited capacity or reduced footprints of humanitarian aid and technical personnel in those local government areas. The fourth adaptation was reduced frequency of follow-up visits. Instead of the weekly follow-up visits or bi-weekly, it was extended to bi-weekly on bi-weekly basis or monthly basis for follow-up, such that we are able to make it more friendly for the beneficiaries. The next adaptation is on the use of MWAC and edema only for admission. Worthy of note is to say that this adaptation has been in play for a long while. However, it has not been documented as an adaptation in this context. Most organizations and most implementers use MWAC and edema only for admission. However, it was this was because of the lack of technical competence and the caseloads in the local government areas. So we have also adapted this to be an adaptation for the admission and management, as well as discharge of wasting in the Northeast Nigeria. And the last adaptation for the SOP is the use of family MWAC. Here we talk about engaging with family members to screen and refer their children who may have acute wasting in this context. Next slide, please. So there are several scenarios and the different adaptations that we agreed upon as part of the SOP. The first one is where there are pipeline breaks or stockouts and delays in supplies of essential commodities for the management of wasting. Single product for treatment is one of the adaptations that will be used, and we have MWAC and edema only, as well as family-led MWAC approach. Another scenario is in areas where we have hard-to-reach areas and the community health-led treatment, reduced visit frequency, MWAC and edema, family-led family-led MWAC, as well as the single product for treatment, the adaptation that will be employed for these scenarios. Next slide, please. In areas where we have human resource challenge, one of the major adaptation is the use of MWAC and edema only for admission as well as treatment. Another is to adopt the community health-led worker treatment, as well as reduce visit and reduce visit frequency, use of single product, and expanded criteria. In areas where we have poor service utilization, talking about poor service utilization, it was agreed that areas who have, there are poor coverage, proximity of beneficiary to the treatment facilities is quite is not very friendly to the beneficiary. Limited community awareness. Some of the criteria we use to define poor service utilization, and we adopted the adaptation for this is community health worker led treatment, reduced frequency, as well as family work. Next slide, please. So in terms of decision making, before the implementation of the simplified approach, the State Ministry of Health, the Primary Healthcare Development Agency, UNICEF, WFP, and the IMAN Technical Guideline will ensure that there is enough awareness on the simplified approach, including the information on the particular adaptation that will be used in that area. The target population, the implication, and the duration. What system in place also to ensure capacity strengthening prior to and even during the implementation of the adaptation. There should be, or there will be, supplies necessary to implement and support TF,
Solomon, we can't hear you. You are breaking.
Oh, sorry. Can you hear me now?
Yes, I can hear you now. Please go ahead.
All right, thank you. So I was saying, in terms of the decision making, also all supplies necessary for the implementation must be available and sufficient, and there must be a buffer stock to cater for any changes in terms of caseload. And there is a proper data collection, monitoring, and reporting system in place to ensure effective reporting on implementation and documentation of lessons learned. Next slide, please. Yeah. So in terms of areas prioritized for implementation and duration, the priority will be given to areas with large numbers of relocated. Other factors that will be considered includes areas which are hard to reach and with presence of aggravating factors. So such as limited access to wash facilities and services. The implementation of this approach also was agreed that it is going to be a temporary strategy to save lives. So it is not going to be a full-time, it is not going to replace the national IMAM guideline that is in place. It's going to be rolled out between a period of 3 to 6 months and no maximum 6 months as agreed in the SOP. It will be stopped immediately upon the activation or scale up of OTP and TSFP and other malnutrition prevention and the area, and an improvement of the aggravating factors in 15 factors in specified locations. Next slide, please. Next slide, my.
Solomon, are you there? You're breaking slightly still. Solomon?
In terms of challenges, one of the major challenges we had was in terms of poor communication among implementers. Because some of these adaptations were already in place before the finalization of the SOP, some implementers just go ahead and implement, for instance, without necessarily going through the normal agreed pro. And one of the ways we are working to meet this in terms is the
Solomon, we've lost you completely. I'm not sure if it's the connection. Solomon? We seem to have lost Solomon, unfortunately.
Yes, Martha,
try
why
to
don't
round up. Yeah.
Solomon, we lost you a little bit. We did hear your last couple of minutes discussion.
So I will say ranges of changes.
I think we're still having problems with Solomon breaking. Martha, can I suggest maybe we jump into
The commitments in terms of additional supplies and that have been a major approach. Okay. The next one is in terms of limited technical capacity, especially in the local government areas. And the last will be the differences between the operational differences between UNICEF and WFP. With partners and implementers preferring more to work with UNICEF in terms of because of the flexibility in getting supplies from them, and the FLA process and logistics demands from. So that has been a major challenge we've encountered in the Northeast. In terms of where we are now, the SOP has been finally been validated by the Federal Ministry of Health in Nigeria, and it is very much operational in the Northeast Nigeria. With, of course, we've had full implementation of, the use of MUAC and edema only admission, the use of family-led MUAC, reduced frequency of visits, as well as expanded criteria in some instances, but we are yet to, like I stated earlier, we are yet to have the use of single products, basically because of the lack of availability of the RETF to do this. So generally, I think that is that for want of, and I apologize for my connection challenges. So over to you for Ellen.
Great. I actually handed over to Martha now to facilitate a good discussion section. Please go ahead, Martha.
Thanks, Elaine, and thanks to Simon, Solomon, Gabrielle. Thank you so much for the wonderful aspects you shared. Thanks, of course, to Grace and everyone behind the scenes trying to make sure this goes well. Now we get into the questions and answer sessions. If, as Grace mentioned, for any questions in relation to this, to the updates of the WHO 23 updates, please refer to the webinar recording. We'll be sharing the link to that. We're going to look at some of the questions that you brought forward, just to emphasize that most of the questions are really in relation to decision making and reporting, and better understanding what some of these approaches are in relation to other terms that are commonly used out there, because there are terms that are used out there to simply mean the simplified approaches, but not necessarily so. I'll have a general question first for all of us. That's for Solomon and Simon, which is simply asking whether any of these adaptations were implemented once you completed the strategies and SOPs. Simon?
Yes, so the strategies that have been implemented include use of single product, expansion, expanded admission criteria, and of course, family work at a number of places.
And Solomon, in your case, in Northeast Nigeria, which of those have been implemented? I know that there were those that were previously implemented even before the SOP was put in place, but what are those that really got implemented following this process?
All right, so what has been implemented so far is the use of work and edema only. That is currently happening, and we have family work that is also currently happening. And during the election and some other processes in Nigeria, the use of reduced frequency was also implemented. So basically, those are the three that has been fully implemented in Nigeria.
Thank you. Simon, you did mention facing barriers in decision making, and so there's a question we're wondering whether the lack of evidence on simplified approaches in Somalia could have been a constraint, and how did you actually engage with the government, or how can we improve engaging government and collaboration with the various ministries of health to improve the uptake and support when it comes to implementing some of these approaches?
Yeah, definitely lack of evidence on how these approaches are different from the normal approaches initially contributed to the barriers. But also this required, as I mentioned, we had a lot of back and forth and engage in consultative sessions with most of the members of the nutrition unit at the Federal Ministry of Health. And also it's just a lot of this, previously in Somalia, there were implementation mostly at the agency level, at the sub-district level. So, but this discussion had not been brought out to the federal, to the national level. So this was quite something very new. The discussion was very new at the national level. So it takes time. So it was a very new idea, and even in normal circumstances, requires a lot of understanding what is the objective, how different is it from the current normal programming, what will be the impact, and to try and understand the whole process. So that's the reason why there's a lot of barrier. As I said, it was a very long process, but the Ministry of Health gave provisional approval, which means not really official guidelines, but we can work with the guidelines to implement, to activate the simplified approaches.
Okay, thank you. I'll still keep you on. There was a question that was raised on reporting by more than one of the participants. How have you handled, and maybe this would also be added onto by Solomon, the reporting of the MAM cases that are treated using RUTF? As traditionally we've had, most MAM cases or MAM programs reporting to WFP, and then the SAM cases reporting to, or the severe wasting cases reporting to UNICEF. So how did you handle where changes were made and you had to also treat moderate wasting cases with RIUTF?
Yeah, this is one of the main challenge. The current reporting tools are very clear. The only indicator for those for the some interventions is severe acute malnutrition by MWAC. And then for the TSFP is moderate acute malnutrition. And the tools are ready, the health workers are fully aware on how to report this. So we had to come up with separate reporting tools in the locations that were implementing these approaches, very ad hoc, so that they'll be able to report those that are admitted by MWAC. It was not it's not a very successful, not very accurate, because the registers are not designed to capture this information. So it's one of the challenges, and hopefully as we are migrating into the DHIS2, is to ensure that both at the OTP or TSFP, it's possible to report either both indicators, SAM and MAM.
Okay, thank you. Solomon, would you like to add something?
Yes. So while we have a challenge, like I earlier mentioned, of some partners not communicating before adoption, we have the challenge of not really knowing what is happening with those cases, and we are not able to really monitor. But for where activation is properly done, the standard tools for the admission and discharge of this both severe and moderate wasting is adopted, but with a caption on saying this is SA on it, using so to note that this is simplified approach. And because we are already aware all information coming from those facilities, we take it as a simplified approach. And we also want even where, for instance, we use expanded criteria, it is very important that we segregate both the severe and the moderate wasting as SAM and MAM, such that we are able to determine what are the caseloads for each category of this wasting. And in terms of monitoring performance, normal performance indicators are used to monitor the performance in those facilities. Over to you.
Thank you. There's now another question, which is in relation to implementing these approaches, which is, Simon, this will direct to you first, and then maybe Solomon, where changing or switching from the standard to the simplified approaches could affect community uptake of these services. What interventions or what strategies did you put in place to ensure that service intervention or uptake continues or even increases when you start using the simplified approaches?
Yeah, one of the main issue is the confusion now on use of RUTF and RUSF. So as mentioned, in most of these places, there's also family MOC ongoing, which is self-referral. And the family MOC, the caregivers are trained. If the child is red, go to the OTP. And in Somalia, the word OTP it's RUTF. And also for TSFP, it is RUSF. So again, it may bring, today we are using RUSF to treat MAM, then tomorrow again is RUTF. Those are some of the risks in terms of changing these approaches. I think it's all to do with awareness, but also let me allow my partner to add to this question. Gabriel.
Thank you, Simon, and thank you, Martha. I think, yes, switching between the approaches can cause a bit of instability in the flow of processes. Generally processes, yes, but also from the community perspective, as Simon has explained, they are used to certain services being provided from certain points. So that can maybe cause a little bit of confusion. But generally, I think what we have seen is that where we have done expanded admission criteria, the awareness created by the community health workers at the community level helps to direct and support the community members to try to ensure that we have that awareness and consistency on where the given services are provided. But along that also came with the capacity building for the health workers and the service providers. So it wasn't such a big challenge, I would say, that we experienced a total shift and a total change in the programming. But yes, there might have been a few minor inconsistencies and a bit of confusion. Thank you.
Thank you very much. There's a question asking, I don't know if it was probably a miscommunication or the participant had issues. They're asking to explain more on the expanding admission criteria to begin from 12.5 instead of 11.5 centimeters. Gabriel, would you please clarify on this? Was it starting from 12.5 or 11.5? So that is trying to explain what the admission criteria is.
Okay, so I think first we need to understand that under normal circumstances, we define severe acute malnutrition with a mark of less than 11.5 centimeters. And then the mom is marked between 11.5 and 12.5. So under expanded admission criteria, and as Simon had explained, in exceptional circumstances where we may not have mom treatment. So we say, let's treat all the children who have acute malnutrition. That is both those that have mom and some with the available product, which is RUTF. So in circumstances where we did not have treatment for moderate acute malnutrition, we then expanded admission criteria to include mom children to treat them with RUTF. That is what it simply means. And so all the children who have some and mom, some with without medical complications and mom were then treated in the outpatient treatment program. Usually that is done, the normal outpatient treatment program by UNICEF. I don't know whether I make that a bit clear.
Yes, yeah, thank you. And this is a general question, so probably I will hand it to Solomon and then we can have a contribution from Simon and Gabrielle. As you do this, you're definitely working on having your M&E and learning strategies. Have you put in place measures, or will you be able to put in place measures to evaluate potential negative effects of some of these simplified approaches? These could be an increase in the relapse due to the use of mark only, and maybe the exit criteria. Potentially, they could also be reduced performance in terms of treatment for severely wasted children. But those who are not classified by this score, but yet are classified as being severe with mark. So some of those and other aspects, have you included that in your strategy, or are you thinking of including such aspects as part of your monitoring and evaluation and learning?
Yes, so like you rightly mentioned, this is a fairly new approach, and we hope to learn a lot from it, from the implementation so far. Partly what we are trying to put in, the IM team, and the assessment and information and technical working group is taking cognizance of those that were admitted in this in terms of performance and recovery rates in those children. We're talking about relapse rates. How many children do we have compared to those who have who are implementing the standard approaches using the IMAM national national guideline, and see where what the differences are. Also looking at in terms of not just the performance on the part of the beneficiaries receiving these services, also in terms of learning from this, what were the bottlenecks we've gotten from this, what are some of the challenges we've had. I've just talked about the communication issue we've had, and how we can move forward from in terms of having those issues. But generally, I think it is still a learning curve for us. We're still building the lessons learned from the implementation of this, and we hope to be able to give more in-depth insights into part of the lessons we are learning from this.
Simon, any additions?
Yes, one of the areas we're very much interested in Somalia is to look at how effective family work would be compared to other approaches. For example, the use of CHW, door-to-door screening, and MWAC screening. Somalia, there's a lot of activity in terms of to be able to mop up all wasting cases using mass MWAC screening exercise. We want now to compare the areas that we know that this family work has been rolled out, and see which one has more impact, which one is more effective. So that is one of the areas that for the other areas is still very early days, and we'll be able to do this once we are rolled out these approaches more. One of the things I would like to mention, and as well question, is on the issue of the outcomes. So far, actually, in the areas that have implemented the expanded admission criteria, treatment of both SAM and MAM in non-location, there is no significant difference. The only issue is possibly because of congestion at the treatment site. Reports of poor quality of care is one of the main issues, because of the capacity at the subnational level. So that is, they have to treat so many children, then the quality of care is low, it's poor. Thank you.
Oh yeah, thanks. Maybe just continuing on the aspect of many children, with the use of a single product, in this case, which is RUTF, that is being handled by UNICEF, you'd have higher number of children and definitely higher or bigger commitment in terms of raising resources. How is this being handled moving forward, given the recent challenges in mobilizing resources? Yeah, Simon, that I think was
yes.
to UNICEF, to Somalia, yes.
Yes, this is the elephant in the room. But as I mentioned, the activation has to be very clear so that it's not scale, everywhere. It's only where it's critical and required. But yeah, it's a very valid concern, and will require support across all stakeholders.
Thank you, Simon. There was a question also asking that now that the CHW treatment is endorsed within the current guidelines, are we looking at getting this established as a standard protocol? And I would like to respond here and say that preferably all questions related to the new guidelines, it's best to refer to the webinar recording, but also to be aware that all these guidelines have different countries will have to update their guidelines. And so I believe that once the countries have updated their guidelines, then whatever is included in the revised guidelines of those countries will be considered part of standard protocol. I had another question. I know that both Somalia and Northeast Nigeria, you said you've implemented the family mark approach. And so I'll pose this to Solomon. What are some of the barriers that have been encountered in implementing the family mark?
I think one of the major barriers we've had in terms of implementing the family mark is in the level of, it's generally been accepted, but it's in the level of sometimes when a caregiver does take the mark reading and refers the child, and is confirmed that the healthcare by the healthcare workers at the facility not to be the child not to be wasted and taken back. It's kind of it sets in some level of discouragement from on the side of the caregivers, and they feel as if they're not being, they are not taking, they are not being taken serious. And of course, it also leads to the fact that they don't take the process too serious anymore, because they don't believe in the outcome of their measurement. So what part of what we do is, where we have quite a number of inconsistent measurements between the caregiver and the health worker. Training is done again for the health workers and for the family member, such that he or she is able to take the reading more precisely and help in getting the care the child requires, and reduce this lack of admission and the discouragement on the side of the caregiver. Aside from that, I think we are also in discussion in terms of getting not just now we can say we have this number of children being admitted based on self-referrals from the caregivers. But what is the impact in terms of comparing it to the supplies you have, the mark tapes you buy, and you having children, or having care, community health workers going to the community to measure these children. What is the difference in terms of the resources required to in these two approaches? So that is part of the things we've not been able to establish. That apart from this sensitivity in timing and detection, we've not been able to determine the economic value of this approach.
Thank you. Simon, please.
Yes, there's an interesting observation here in Somalia. We have there's been a culture of issuing out referral slips, and because of frequent scale up and massive interventions and screening, so caregivers feel they only get the confidence to go to the health facility if they have a referral slip. So even it comes to the issue of mock screening. I've had the reports that they again, they do the self-screening. They have again to go to the community health worker to get that referral slip, so that they can get the confidence to go and access services. It's a very interesting observation that, and I don't know how widespread is that, but I've reports that it's also undermining the role of the community health worker. But I think it's all about creating awareness, and also other, the frontline workers, the health workers. Their practice is to admit if you come with a referral slip, and that's where it starts. So it's to require a lot of also awareness among the health workers to fully embrace this approach.
Okay, we're almost getting to the end of our session, but I'll just quickly question to Solomon. I think you mentioned that the SOP can go up to 6 months. the question was, why do you want to suspend this after 6 months, especially in a country where you have a high burden of wasting? And especially given that aspects of these SOPs are really based on the new WHO guidelines. So why would you want to suspend the use of this SOP after the 6 months?
Okay, so basically, we have said this SOP is a temporary measure. As at the time we were developing the SOP, is a temporary measure, and it does not replace the national guideline we have in place. Most times it is deployed to provide immediate life-saving intervention in those areas where we have limited humanitarian presence and technical capacity. But now, in terms of why we need to, the quality of care is one of the things that you also you want to look at in terms of the implementation of this simplified approach. When you have the simplified approach running for a very prolonged period of time, there's the risk of reduced quality of care. Also, there is the risk of not having a holistic nutrition intervention in that area. So we have while that is happening, the nutrition sector will be monitoring the situation, and UNICEF, WFP will also be strategizing on how best to bring in a more sustainable intervention in that area.
Thank you very much. I wish we had a bit more time to respond to all the questions, but the panelists will continue responding to the questions as we go ahead, and we'll share the responses. As we come to the end, this is a question to you, Simon and Solomon, and probably a minute each. Now that you've gone through the whole process of developing strategies and SOPs in regards to exceptional circumstances, based on this experience, is there anything you would do differently if you're given a chance to repeat the process? Simon, you can begin, and then we'll end with Solomon. Thank you.
I think what I would do, the thing is that I would do differently is directly engage the government at the regional level and the state level before going to the federal level, so that
Okay.
by the time we are going at the national level, there's a complete buy-in at the subnational level. The other thing is also differently is look at activation, not from a very broad area, but try and also see whether there are ways we can look at scenarios at household level or very much lower level than with the district. So those are the two areas that we do different.
Thank you, Solomon. What else would the Northeast Nigeria team do differently?
I think what we could do differently is have one, WFP, UNICEF, first of all, agreeing to and making commitments to these approaches, such that we have their full buy-in before we are able to scale up the discussion with other stakeholders in the development of the simplified approach. Because what we have now is that the difference in operational styles has a way of not giving the full support that we would require at to fully implement this simplified approaches. Aside from that, I think one other thing we'll do is to bring in the GNC much more sooner than we did in the development of the simplified approach in Nigeria. Maybe at the beginning it will have gone a long way in helping us. Yeah, over to you.
Thank you very much. I'll hand over back to Elaine. Thank you.
Thanks, Martha. We have unfortunately run out of time. Lots of good questions and a good discussion. As you've seen in the chat box. All of the resources, including the slides and the recordings, will be available on the GNCTA website very soon after our time here today. I want to say a huge thank you to our panelists, Simon, Gabriel, Solomon, as well as our facilitators, and to Grace for her opening remarks. Martha, that was a great conversation. Thank you for that facilitation. I also want to say a huge thank you to our audience for maintaining your patience with us through some slight technical difficulties. As you are aware, it is sometimes difficult to connect, so we appreciate you staying with us. A few reminders here at the end. If you are looking for support for nutrition in emergencies, there are a variety of different types of support that are available through the GNCTA, including remote and in-country in-depth technical support, support to hiring a consultant, quick and responsive technical advice, and then of course peer support through NNet. You can access all of that on the GNCTA website, which you can see here on your screen. From the Delivery Systems for Scale project, this is the second webinar in our series, and we do expect to have one more webinar coming up on the results of a global scale study that has been led by Diane Holland that really kind of summarizes some of the key milestones over the past decade that we've seen in trying to bring wasting treatment to scale. That is yet to be scheduled, but you'll see that coming out over the next couple of months through the GNCTA once it is scheduled. So again, thank you all for joining us. You'll see a brief webinar evaluation popping up on your screen. Please do fill it out so we can understand how relevant and interesting this webinar was for you and integrate that feedback as we move forward. Thank you for joining us. Please do access the webinar resources once you're able to, share them widely, and we hope you'll join us again in the future. Thank you.